our CIC lecture, as always. Today we have Dr. Roberta La Piana, who is an assistant professor in the Department of Neurosurgery and Neurology of the MNI and an associate member of the Department of Radiology at McGill University. Her research focuses on the application of MRI pattern recognition to define and characterize genetic white matter diseases, the identification of novel genes responsible for new forms of hereditary white matter disorders using next-generation sequencing techniques, and the understanding of clinical and MRI overlap between immune inflammatory disorders and genetic leukoencephalopathies, which is literally white matter diseases in the brain. Since 2013, she is the coordinator of the White Matter Runs Network, initially held locally at the Neuro with the goal to discuss atypical white matter diseases. The White Matter Runs has evolved into an international network, which now includes more than 15 centers around the world. Let's welcome Dr. Roberta La Piana.
Thank you, Yuan, for the presentation. Thank you for being here. Thank you for inviting me. I had been looking forward to being at the Douglas for reasons that you will see in the presentation. This is the title of my presentation. And we will be, okay, good. So I just wanted to give a brief introduction about what genetic leukoencephalopathies are, because maybe not all of you are familiar with the concept. So initially, I'm a pediatric neurologist by background. And when I studied, when I was in my residency, we were taught that genetic leukoencephalopathies are inherited disorders of myelin. Well, this definition evolved over time, it changed, and now we consider leukodystrophies or genetic leukoencephalopathies any hereditary disorder that affects any elements of the white matter. This means, of course, disorders of the myelin, but also astrocytopathies, microgliopathies, vascular white matter diseases, and those disorders that affect the interface between white matter and axons. So you already see how the landscape is much more broad than we initially considered. But what is really my area of research interest is the overlapping with the multiple sclerosis spectrum. Why is that? Because, again, historically, we have always considered genetic white matter disorders as being disorders of the pediatric population. So the peak, let me see if I can, yes, the peak really in the very first years of life. While when you see white matter abnormalities in young adults, you think about the MS spectrum, multiple sclerosis, and later on in life, it's the big concept of leukorrheosis or, in general, vascular white matter diseases. But the point is that there are more and more cases of atypical multiple sclerosis, especially the primary progressive forms that are seen. And we have more and more genetic entities in the vascular white matter diseases group. And we should not forget that 30 to 40% of all genetic white matter diseases remain undiagnosed because we haven't identified yet the genetic cause. So based on this, these three concepts are really the basis of our research question, which is whether by combining imaging with genetic techniques and clinical phenotyping, we can identify new forms of adult genetic leukoencephalopathies in that specific age group that are not recognized as such as of today. So what is the technique we rely the most on? It's MRI, because I will present you a lot of clinical MRI. I know that you are more into sophisticated and quantitative techniques, so bear with me. You will see a lot of images. Can you see them? Should I turn off the light? No? Can you see the abnormalities? Yeah. Okay, good. So I put a normal MRI for reference, a normal T2. I'm sure you're familiar with that. But usually, the concept you learn in books is that when you see diffuse and symmetric white matter involvement, you think about genetic. When you see something like this, so in which you see focal, especially when oval-shaped lesion, asymmetrically located in the two hemispheres, you need to think acquired, you need to think multiple sclerosis. Is this always the case? Well, this is almost always the case in pediatric leukodystrophies. But what about adults? And that's why I got fascinated by adult onset. Well, there are some MRI pattern recognition approaches that can be used. And yes, we can definitely identify some disorders based on the predominance of the white matter abnormalities. So for example, if I see predominantly frontal involvement, I think about the leukoencephalopathy with the axonal spheroids caused by variants in the CSF1R gene, and so on. You see, a posterior predominance is usually related to Krabbe disease, and you go on. But this would be too easy, and things are not that easy. Otherwise, we would not do research on it, right? Because the problem is that in adult patients, there are many forms that actually present with multifocal involvement that many times mimic multiple sclerosis lesions. So I showed you here 4 patients with 4 different disorders. And actually, these are disorders caused by different cellular type involvement. So in this case, it's a mitochondrial disorder. This one is a microgliopathy. This one is a collagen 4 related disorder, so a vascular leukoencephalopathy. I'm going back. And this one is, again, another small vessel disease. And you can see that in these patients, we can recognize focal lesions. Look at this one. This one looks really demyelinating. There are multiple lesions. And here also we have the classic perpendicular lesions that look like multiple sclerosis, but these are all genetically determined. So we started, in my lab, we started saying, okay, but why genetically determined white matter abnormalities look like multiple sclerosis in adults? What is there evidence for these overlapping phenotypes? And the answer is yes. So for example, in some forms, these are very well-studied forms, adrenoleukodystrophy and Alexander disease. We know that patients can have contrast enhancement. So it means that there is a blood-brain barrier problem that leads to a central inflammation. We are talking about inflammation. It's something that usually we consider typical of MS, not of a genetic disorder. The other element is the fact that in several genetic disorders, they found oligoclonal bands, so an intrathecal production of immunoglobulins. Interesting, right? So among these, you can see that mitochondrial disorders are among the most common. And if we dig a little bit more into mitochondrial disorders, there is this beautiful review article that I invite you to read if you are not familiar with that. But there are many mitochondrial disorders that can really be misdiagnosed as multiple sclerosis, and vice versa. And that's, to me, is what particularly interesting. In patients with diagnosed multiple sclerosis, they found variants in mitochondrially associated genes. So there's definitely an overlapped pathophysiology. So what we did in our lab with Hanifa, who is she's still a master student, but she has just submitted her thesis. We tried to review all the literature to identify all the forms of mitochondrial disorders that can be misdiagnosed as multiple sclerosis. And we found 8 different diseases and more than 20 associated genes. So this gives us a good landscape of how many different genetic pathways can be shared with multiple sclerosis. The list is definitely not exhaustive because we are discovering every single day new genetic mimickers of multiple sclerosis. And I'll give you the example of this disease because it's something that we have worked on quite recently. So this disorder is a mitochondrial encephalopathy caused by mutations in the TOFM gene. It has been described usually in children with a very early onset, devastating leukoencephalopathy. You see the degree of white matter involvement associated with malformations, cortical malformations, early onset lactic acidosis. Basically, these patients have a multisystemic involvement that lead to that before the 2 years, the first 2 years of life. Classic genetic pediatric onset genetic leukoencephalopathy. But a couple of years ago, we saw this patient. She is a 37-year-old patient. At the time, she was 37-year-old with recurring episodes of lactic acidosis. She was known to have a sensory neural deafness, and she had learning difficulties since childhood. When we examined her, she was short, and she told us, incidentally, that her 2 kids were born after in vitro fertilization because she had some fertility issues. So we connected all the dots and we said, can this be mitochondria? And we actually found a combined decrease in several complexes of the mitochondrial respiratory chain. The MRI, though, looked like it could mimic MS, and she was initially suspected as having MS by a peripheral hospital. So we did a whole genome sequencing, and we found 2 compound heterozygous variants in this gene. So what's the take-home message of this? Is that I really find fascinating the fact that what in children looks like a simply very progressive degenerative disease, in adults look something like more inflammatory. So, but with the same genetic defect. So what's going on? What are the factors that leads in adults to present as an inflammatory disorder? What can imaging bring more to the table? Well, we did 7 Tesla MRI on this specific patient. This is part of the work of Jianyu with one of the students in the lab. And because we said maybe 7 Tesla MRI can help us distinguish between genetic MS mimickers and real MS. And it's true, it can, because you see how at a clinical MRI, this looked like, can you see? No, I'm sorry, I thought. This can look like probably 1 lesion, but when we do 7 Tesla, we recognize that actually these either it's multicystic or these are 4 different lesions that look like coalescent at a lower field MRI. Even more interestingly is the fact that we found the central vein sign, which I don't know if you know that, but the central vein sign, so the fact that you can identify a vein at the center of the white matter lesions in MS is considered diagnostic when the threshold of this sign is found in at least 40% of the lesions. Interestingly, we found it in 30% of the lesions. So they are really the same. They just don't look the same. They are really sharing pathogenetic mechanisms. Okay, this is for mitochondrial disorders. Let me introduce you another group of diseases that I really like. So this was a 45-year-old patient, you see her here, with a particularly important psychiatric family history. So the mother is known for a long-standing drug-resistant bipolar disorder. The sister, the older sister, has a psychotic disorder. She refused to undergo any type of investigation because she has really some paranoid features. Our patient presented with a drug-resistant depression. She was put on a leave of absence, permanent leave of absence for work because she couldn't cope anymore with the tasks. And she then started showing signs of cognitive declines, being apathetic, incapable of taking care of herself and children. This over the span of 4 to 5 years. She was treated with, I don't know how many antidepressants. She finally was sent to the neurologist only when the husband noticed that her gait was slowed and quite broad-based, and that she was stuttering when she was talking. At that point, she also had some episodes of urinary and fecal incontinence. And when we examined her, we found that she was ataxic, she had rigidity, the speech was really limited, and she had a very severe emotional lability. So this is the MRI of this patient. Can you see? The corpus callosum is really thin at the level of the anterior portion of the body. There is a bilateral frontal involvement, but would you say it's symmetric or asymmetric? Who's for symmetric? Asymmetric? Yeah, we agree. It's clearly asymmetric, and if we look more at a higher level, it really looks patchy. It's not really diffuse. So at that time, it was in 2014, we had big discussions, and we even thought that this could be like a gliomatosis cerebri. So that they said probably this is a tumor. So they biopsied her, and I will tell you what we found. But a few years later, the brother came to see us saying, I don't think I'm doing well because my coworkers tell me that I'm not the usual guy. I lose my temper, I'm always the cool one, and I'm not the cool one anymore. So we did an MRI on him, and we found, well, the corpus callosum was still fine, but he had clearly bilateral frontal involvement with corpus callosum involvement. And look at the MRI. Here, it's even more asymmetric than in the sister. And look at these lesions, very multifocal and very perpendicular to the ventricular wall. But what is really pathognomonic of the disease is the fact that he had areas of persistent restricted diffusion. It's persistent, it's not a stroke. So what this is that? This is adult leukoencephalopathy with axonal spheroids and pigmented glia. It's very rare, It's very underdiagnosed, actually. We diagnosed that simply because, as I told you, we did the biopsy, and we found that these abnormally swollen axons with spheroids in the sister, who passed away a couple of years later. The brother has also passed away now, because this disease is really very severely progressing. They pass away, usually the death occurs approximately 6 to 7 years from disease onset. The psychiatric presentation dominates the onset, usually in 40 to 50% of the cases. That's how they start. And that's the reason why it is often misdiagnosed with other psychiatric diseases or frontotemporal dementia. And there is a very high intrafamilial variability. But why this is particularly interesting for what I'm telling you today is because it is caused by mutations. I keep using the pointer on my screen, I'm sorry. On the CSF1R gene. And the CSF1R gene is the colony stimulating factor 1 receptor for microglia. So this gene is crucial for microglia, proliferation, differentiation. And if you work on demyelinating disease, you know that microglia is the hot topic in MS research. And I put you here the amount of articles that have been published recently in microglia in MS. And look, there is a particular interest on really the CSF1R signaling. So again, it's not incidental that MS and genetic disorders look the same, because there really are shared mechanisms. So what we are doing about this. So we are working together with Joanne Stratton and Thomas Durkan at the Neuro. And basically, we are taking the cells from these patients. In our lab, in my lab, we do the genetic characterization. And then in in Tom Durkan's lab, we do the generation of iPSCs that we then differentiate in microglia. And then we try to see how these mutated microglia can impact myelinating axons. So these are the results. Basically, it was super hard to grow these cells because they are lacking the receptor that makes them proliferate. So good luck in making them grow. But we finally were able to do that. And what we found, this is the work of the PhD project of Diana and Marie-France Dorion. So basically, we found that you see how this is the viability of the cells. So in patients, it's really limited. We have to work hard to look at them. But we found that basically the surface expression of the CSF1R gene is reduced. And the same thing occurs to this gene, which is much reducedly expressed, and is basically an indicator on the fact that there is a decreased migration of microglia. Okay, let's move on to the next step, because up until now, I just talked to you about the diagnosed form. But actually, more than 30% of adult patients with genetic leukoencephalopathy don't have a final diagnosis. And this is actually our daily practice. So many of these patients don't have a final molecular diagnosis because we haven't identified the gene yet. And what do we do with this? So you see, I presented you here 3 different patients, and you can see the different clinical presentation, but many of them actually present with either a cognitive decline, a progressive cognitive decline, or with psychiatric symptoms. And they all have a bilateral involvement, but very multifocal and very asymmetric. So in my lab, what we do is that we try to do the radiological characterization. We try to put them together in clusters of patients with similar clinical and MRI phenotypes, and on those we do next generation sequencing using whole exome or whole genome sequencing to try to identify the genes, and then we go back to redefine the radiological phenotype. So the patients are seen in our white matter clinics, which are basically, it's Dr. Bre and myself seeing them in a research clinical context, and these are our fellows who have helped us tremendously identifying all these patients. And these are the criteria we use to include them in our study. So this is also just to tell everyone working in the clinical setting, either in the room or online, if you see any of these patients and you want to send them to us, we are happy to examine them and to assess them and to include them in our study. But of course, we are talking about very rare diseases, so we cannot do this alone. So that's the reason why in 2013, we launched the white matter rounds, which were initially, as you see from the photo, pre-pandemic. It was these were monthly meetings. We were meeting in the radiology or in the Grand Prix auditorium at the Neuro, and we were MS clinicians, radiologists, geneticists, and we were discussing all the undiagnosed cases. But the point is, as some colleagues of mine have said, everyone has skeletons in the closet. So this attracted the interest of many people. So with the years, we have grown significantly. So we are now more than 20 centers around the world, including Australia. So it's a bit difficult now to coordinate the time, but people in Australia are also very motivated to attend our rounds, so they connect at 8 p.m. And we have also launched last year this White Matter Rounds website, so where you can access the videos of previous rounds, but I didn't show them here, of course, for confidentiality issues. But you are all welcome to join us if you are interested in white matter diseases, or if you want to learn more about the topic or share some cases. this is really to tell you how important I think it is to collaborate when you're dealing with rare diseases, because it's only by putting cases together that we can find a final diagnosis for these patients. But I'm talking here at the Douglas, and I don't forget that this is the Center for Psychiatric Disorders. So let's go back a little bit to this initial slide. What about the clinical presentations? So if in pediatric patients, we see usually a presentation characterized by developmental delay, motor regression. In young adults, we usually see motor and sensory deficits, and later on you see dementia, cognitive decline, stroke-like episodes. One feature that really is characteristic is the fact that in that age group, so in the 2nd to 4th decade of life, the psychiatric presentation is really predominant. And what's the impact of missing this diagnosis? Well, one, I put 2 articles, then they are not even that recent, but they illustrate pretty well what is the impact, not just on one single subject, but on an entire family. In the case, for example, of cerebral X-linked adrenal leukodystrophy, the impact is that these patients can miss time-sensitive treatment opportunities. Because they can miss the only treatment opportunities is hematopoietic stem cell transplant, which should be done in the very early phase of cerebral involvement. You miss that, and the patient cannot be treated anymore. In the case of CADASIL, which is an autosomal dominant disorder, missing a diagnosis means that patients, that entire families can miss the genetic diagnosis, the genetic counseling, and the prenatal diagnosis opportunity. So really, we need to be quick at identifying them, send them where they can be diagnosed and offered appropriate counseling. But what are the classic psychiatric signs in these patients? Well, the classic one are the chronic symptoms that usually arise late adolescence, early adulthood. And these are patients who present with mild depression, anxiety, learning difficulties, behavioral changes, and you see on the left of the screen the list of diseases that typically present like that. But there is another group that present psychiatric features only in the context of a secondary in the sense that it comes after neurological involvement of a mild cognitive deficit. So please keep in mind that genetic leukoencephalopathies present very often with psychiatric features, either very early in their clinical presentation or later. The data from our cohort, as you can see, is that psychiatric symptoms are present in 17% of our sample of 105 subjects. And the large majority of them are present at onset, are the presenting sign. As for the cognitive impairment of or decline, they are more than 1/4 of patients, and again, 1 in 2 of these present at onset. This is the last case that I'm presenting to you because I think it's very illustrative of this is really the classic story that we see. Consanguinity, French-Canadian family, again, important familiarity for psychiatric issues. So 2 uncles died by suicide, and there is this psychosis, schizophrenia in the grandmother. Our patient, a 41-year-old man, when we investigated his personal development, the mother told us that the motor milestones were normal, but he had very, very important behavioral issues since the age of 8 with sexual abuse on the sister and really something very significant. He attempted suicide the first time at the age of 16 by driving with his car into his home. So he wanted really to destroy not everything. But despite that, it was simply removed from family by the Centre de Jeunesse, and no investigations were done. Even though there was one red flag that should have raised some suspicion. And it was the fact that since the first suicidal attempt, he had enuresis. So he had a urinary incontinence. Anyway, the story continues at the age, well, in 2009, so he was 30-something. He had 2 episodes of major depression, again with suicide attempts. And following the second suicide attempt, it was really, he tried that in a very traumatic way. I'm saying this because it's relevant for the story. He was admitted, and they found the memory issues that were not present before, difficulty walking and impaired balance. He used to work as a truck driver. It's only while he was working, he was involved in a car accident and he had then a mild brain concussion that they did and had CT. And they found an important periventricular bilateral white matter disease. So they did an MRI. Do you notice anything? Well, there is a diffuse bilateral, in this case, a symmetric white matter involvement, mainly periventricular, sparing the U fibers. But can you see those? You see that there are cystic areas of very focal cystic degeneration, really white matter rarefaction. Look how beautiful it looks in the sagittal. So this is diagnostic of vanishing white matter disease. And actually, when we saw that, we said, okay, that's it. We did the genetic testing, and we found an homozygous mutation in the gene. So what is vanishing white matter disease is an astrocytopathy. So we are talking again about astrocytes. So I mentioned microgliopathies, mitochondrial diseases, vascular white matter disorders, and now astrocytopathies. And the adult onset is in 15% of cases. And what is interesting is that those genes are all involved in the stress response. So these patients characteristically deteriorates every time they have a trauma. It can be an infection, it can be a head trauma. Anything can really trigger this acute demyelinating event. Look at the MRI. This is what happens in children. Really, the white matter is virtually absent. It's all replaced by CSF. In adults, what we see is really what we have observed in that patient. So limited areas of cystic degeneration around the anterior horns of the lateral ventricles. Importantly, 62% of affected women present with ovarian failure. So it's always important to investigate the fertility history in patients that present, for example, with psychiatric, long-standing psychiatric problems. And I already said that it's characterized by rapid deterioration, and that's it. Yeah, it's important to diagnose these patients early to prevent episodes of future deterioration. So when we saw how many patients present with psychiatric or cognitive issues, we decided to write this review paper, and in which we designed an MRI algorithm to guide the diagnostic process when you are presented with an adult patient with white matter abnormalities and psychiatric presentation. So this is what we did. So if you happen to see a patient with these features, you can use our algorithms and try to see if we can get to a diagnosis. So I'm almost done. The conclusions of what I told you today is that very simply in this age group, oh, sorry, the x-axis is not great, but anyway, in the second to fourth decade, that's where we see the peak of genetic forms mimicking multiple sclerosis and inflammatory disorders, and that's where we need to do more research to understand the overlapping. And interestingly, it's also the same age where we see the peak of psychiatric presentations. And the forms that are more associated with these forms, with these overlapping forms, are astrocyte disorder, microglial disorder, vascular white matter disease. So that's again where the money should go if we want to understand more about genetic diseases and about multiple sclerosis. And with this, I have finished. I, of course, thank all my lab, which are here, and my funds. And I'm happy to take questions. Thank you.
Okay. And thank you, fantastic, very interesting. And I was wondering what the prevalence of these genetic white matter disorders were, maybe relative to like multiple sclerosis.
Yes. So the very good point. Collectively, they are super rare individually, but collectively, because we are talking about many forms, they are not that different than the prevalence of multiple sclerosis. So just to give you an idea. When I say it's underdiagnosed, you may find, I know that you're using the UK Biobank for your study. So there's a recent paper that came out from David Lynch group in London, UK. And they looked at the prevalence of CSF1R, you know, the disorder with steroids, CSF1R pathogenic variants in the UK Biobank. And they found that it was super high. I don't remember anymore the number. But, and then, so they said, okay, so this disorder is actually underdiagnosed. Of course it's underdiagnosed because the age of onset is, can span from the fourth decade to the sixth decade. So maybe you have patients into the biobank that haven't developed the disease yet. But interestingly, but in the clinical and demographic data that emerged from all those patients was that the majority of them had a familiarity for psychiatric disorders. So how much wide is the spectrum? We don't know. How much the expressivity of the disease? I don't know. Of course, the prevalence is difficult to calculate when you don't know how the disease is expressed.
Wait, follow up to that. Is there like an ICD-10 code associated with those diseases?
You're using that for your research? For genetic leukoencephalopathies, probably there's one for leukodystrophies. I think there's one for leukodystrophies, but not for each specific form. And again, the problem is that it depends if the patients have been diagnosed or not.
Thank you.
So given what you just revealed here about the UK Biobank and the results you presented, should genetic testing be a frontline component of diagnosis in psychiatric facilities?
If you ask me, I say yes. But it depends. When a couple of years ago, I presented at the psychiatry department at McGill on Pine Avenue. And I gave them as a red flag some red flags as to when to do a genetic panel, for example. And one of the red flags was when you have a drug-resistant patient. And they said, but all of our patients are drug-resistant, otherwise they don't come here, they are just treated by the family doctor. So probably the second red flag should be when you see, I know that psychiatrists don't do a regular neurological exam, But investigating, like in the case that I showed you with urinary incontinence since the age of 16, that's not normal. So going a little bit beyond that would be important. And definitely the family history. I know, again, that psychiatric disorders have by themselves a family history. But in some cases, when you really see a clearly genetically determined pattern, probably I would do that. I honestly would like to do like a panel on everyone, but I would do an MRI on everyone, but I cannot. Thank you.
Hello, very good presentation, thank you. I have a question regarding the family history of these genetic disorders. Because a lot of the time, the environment you grow up in is also going to dictate the connections and how the brain develops. Is there a way you've thought about of detangling the effect of the genetics versus the environment that you're growing up with and how it's affecting the brain?
So we are, yeah, that's exactly one of the questions we are starting to explore right now. Because if I can say something, but really this is not published, this is not, we are really at the embryo stages of investigating this. One thing that we have observed, again, it's a pure observation, maybe it's just anecdotal. But in the last year, we have seen a considerable, let's be precise with the terms, a considerable number of patients that have housing insecurity. And we started saying this cannot be incidental, that so many patients are either in a state of homelessness or almost homeless. And in other neurodegenerative disorders, you don't see that. And one of the reasons why one of our hypotheses is that maybe the fact that this is a genetic disorder, so maybe there are one of the parents is already unwell, so they cannot provide enough. So you see how closely knit the two factors are. So what we are trying to do is that we are trying to use data from our cohort and match that with a cohort from the public health department that has access to, for example, the patient with financial and housing insecurity, and see whether we can disentangle a little bit that. But yeah, that's absolutely, that's a super important question.
Thank you for your result. It's always nice to be putting inside of research. I had a question in terms of the ovarian failure.
Of them, I
The
didn't.
ovarian failure.
Yes.
That over 60%, with ovarian failure end up with these white matter disorders. What type of ovarian failure is that? Is that post-puberty? Is that throughout the menstrual cycle?
No, it's a primary ovarian failure. Those patients have a primary ovarian failure, so they have fertility issues from the very beginning. But I talked with some of the students today at lunch. We are more and more interested in the sex differences because in that specific case, in vanishing white matter disease, we know that those genes are also expressed in the ovary. So we know that there is a problem in both systems. But in mitochondrial disorders, for example, it's true that mitochondria are ubiquitous. But why do they have more fertility issues and are associated with brain deterioration, for example? So that there are many in the other disorder that I presented you, the axonal spheroids one. Women tend to present later, but when they present, they tend to present more aggressively. And again, we are talking about the perimenopause age. So of course, the question is, are estrogen playing a role? The fact that there are lower levels of estrogens, and then you deteriorate faster. So that's why I want to discuss with people working on neurodegeneration, because I think we can do many things. Did I answer your question?
Yeah, you did. Like a follow-up question to this is, do you think before perimenopause, the fact that they have some females are acyclic or they have again their brain failure, is that does that lead to a bigger risk factor, or is it more related to the perimenopause?
No, it depends on the disease. It depends on the disease. For example, in vanishing white matter disease, it's really that they have, again, they are acyclic forever, that they have always been acyclic. But for example, we observed in one case that we published that the patient presented an acute deterioration and acute demyelination when she underwent a fertility treatment for an in vitro fertilization. So again, it's not just the gonad that doesn't work, it's the fact that there is a response to hormones that triggers the demyelination.
Thank you. Hi, I was just wondering, what, because you mentioned the microglia, the mitochondrial problems, but there wasn't much about oligodendrocytes. So I was wondering what's happening. Are there like any genetic things or?
That's the I don't know. Yeah. I think personally, I think that the reason why not many diseases in adults affect the oligodendrocyte primarily, it's really, it explains why many of the diseases that we see mimic something inflammatory. Because when you have a primary oligodendrocyte disorder, what you have is that you have a pure demyelination, right? Or hypomyelination. Either you don't develop and deposit myelin, or you lose the myelin, but you don't have the inflammation. If you have the inflammation, it's because either the microglia is involved, or the astrocytes are involved, or some inflammatory related pathway, for example, mitochondria are affected. So I think, to me, the two things are going together. Oligodendrocyte related disorders are the most common type of disorder in pediatric genetic white matter diseases. More than 50% of pediatric leukodystrophies are due to oligodendrocyte problem.
Thanks for a great talk. It's also fun to like listen to some of them, learn a lot at the same time. So thanks for that. I have two questions. The first is, so in this, in these rare disorders, you have the obvious advantage of trying to understand the biology a bit because you have a genotype that's that you can well characterize these if it's not already. So if you look at those genes and you look at maybe the biological processes that, if you do like a Go analysis or something like that underlie those genotypes, and you kind of overlap them with what you know about psychiatric disorders, with primary diagnoses, psychiatric disorders, or MS. Do you see overlap? Or are they really kind of two distinct biological entities with similar phenotypic characteristics?
No, that's what. No. That's why we are doing this study with Joanne Stratton, for example. We are really because she's an MS person.
Yeah.
And when she heard about this, we both said, okay, but this disorder can really be a great model to study MS, because MS is an acquired multifactorial. Here we have something very similar, which is simply monogenetic. So, and actually what we see is that in some cases, they are almost undistinguishable. So you cannot really tell them apart, because probably the end result is the same.
But you can't tell them apart.
No, even biologically. Well, the fact that, for example, at the cellular level, we aren't there yet, for example, for many diseases. But what I showed you about the presence of the central vein sign in mitochondrial MS mimickers, it's clearly, so they are using the central vein sign to diagnose MS, and we showed that a patient with mitochondrial MS mimicker has exactly the same rate. So it's we are working on that. So to answer your question, in a couple of years, I will tell you what's going on at the microglia level of, for example, that disorder.
And I'm curious to know a bit more about the algorithmic work that you the algorithmic work.
Yes, yes, yes.
You just kind of flew by.
Sure.
If you don't mind me talking a bit more about it?
This one, you mean?
Yeah.
So we basically use only the disorders that are known. Okay, so only those genetically determined for which we know the genetic disease causing gene. And the criteria we used is that first we separated, we classified the classic confluent and symmetric white matter abnormalities versus the multifocal ones. And after that, for the confluent and symmetric, we classified those non-hypomyelinating versus those hypomyelinating based on the T1 and T2 signal. And then we used a regional criterion, so frontal predominance, diffuse periventricular prior to occipital and posterior fossa. While for the multifocal, the known disorder are basically all vascular, and these are the ones that we had. So basically, that's the approach we had. We are updating this algorithm with all forms, so also those for which the disease-causing gene has not been identified yet. So probably that would be helpful.
So right
You
now
had
it's
ideas?
T1, T2
No.
application.
T1, T2 type of fibers involved. For example, U fibers versus association fibers versus, and associated features. So for example, the presence of abnormalities, microischemic changes in the basal ganglia or in the brainstem. Yeah, this was meant to be a clinical tool. So we had to be very basic. Of course, if we could add the diffusion, susceptibility weighted images, of course, this would be much more specific. Thank you.
If someone is diagnosed with any of these very rare diseases, what the medicine can do for them after?
Not much, unfortunately, except for some forms for which, for example, there is sorry, I rephrase that. In terms of treatment, there is no cure for many of them, for most of them right now. For some of them, so symptomatic treatment. For some of them, adrenoleukodystrophy, metachromatic leukodystrophy, hematopoietic stem cell transplant can be attempted at the very early stages of the disease. It has been tried on the axonal spheroids disorder as well. But there's a problem that the disease progresses as well. And for example, one thing that has been observed in the axonal spheroids disorder is that you do the hematopoietic stem cell transplant, the motor symptoms stop the progression, but the cognitive decline continues. So there were families having a higher burden because I have now a mobile husband that continues to deteriorate. So it should be really considered. Besides the treatment, what can be done, which is super important, is the genetic counseling, because most of these disorders are autosomal dominant. It means that at each pregnancy, if you have the disease, you have 50% chances of passing it to your children. And again, the age of onset is 30 to 40. So these people many times have already had children. So you see the implication is really.
Sorry, there's some questions.
Oh, in the chat.
online. I noticed.
Your
So-
last one.
Just the last one, yeah. Just a general question about your presentation. Is the same for both progressive MS and relapse remitting MS?
No. No, it's not the same. The genetic forms mimic specifically primary progressive MS. Some of them can also mimic relapsing remitting MS, especially those that I showed you for like vanishing white matter disease that can present deterioration following head trauma or infection. So in that case, clinicians can misinterpret an episode of clinical deterioration as a relapse, but mainly it's primary progressive MS. Thank you.